Yeah, good morning. Dear Chairman, ladies and gentlemen, dear Thilo, thank you for the kind introduction. It's a pleasure for me here to be here and give this presentation on extended pancreatectomy in borderline and locally advanced pancreatic cancer. Yesterday we had a couple of good sessions about this topic already. We heard a lot about neoadjuvant therapy, the role in it, and today I want to more focus on the surgical aspects, in particular on resection of additional organs that are needed. Starting with these two papers by Webeke and Esposito, we know that an R0 resection is not good and that we need at least a margin-free area of 1 millimeter to get really good long-term prognosis. This was in the Heidelberg experience presented by this manuscript by Strobel et al. And there the R0 resection group, the pointer is here, this is the one where we can achieve long-term survival, 40-month median survival, 30%, 5-year survival, and therefore we need to get real margin-free areas when we resect pancreatic cancer. This is the aspect 3 data, a huge trial, and there again it's important to achieve resection-free margins and all 4 areas, all 4 resections, and the better you get it out, the longer is your survival. So the most relevant predictive factor is R0 resection according to the revised classification by the British Royal College of Pathologists. We all do this by radical surgery along the main vessels, the portal and the portal vein and the superior mesenteric artery. We free this area. This is the mesopancreatic resection, and in addition, in some cases, you need a portal vein resection, you need a resection of other organs. And to be clear what we are talking about, it's this area, the borderline and the locally unresectable patients we heard a lot about. You don't need to do extended resection. The localized tumors, former studies showed that there is no impact on survival, but here this is where the game is playing. And there is a radical resection of borderline locally advanced tumors. It's always about the resection of vascular structures, and it's about the resection on other organs. And that depends on your experience, on the experience of your hospital where you're working on. And I will focus more on the organs. Professor Nakar will more focus on the vascular structures, but for sure there is an overlap, especially when we look in the data of the papers. In 2014, the ISGPS focused on the definition of extended pancreatectomy. We defined what is a standard resection, what is an extended resection. There are always multiple terms, like also multivisceral resections. We should not use it anymore because a Whipple procedure is a multivisceral resection by itself. So extended resection is the term. And in this manuscript, or in this paper, there was a literature review, and it focused on the additional organ resection, and it focused on the vascular resections because the studies available at that time, they were not really going into these different aspects. So the largest study that was included in this review was the one from our group. We had 101. We called it, at those time, multivisceral pancreatectomies, and we compared it to a group of a matched group, 202 patients with a standard resection. The important thing, it becomes relevant later on, the pancreatic ductal adenocarcinoma group was about 70%. There were also other ones like endocrine tumors, adenosquamous, cystic tumors, or acidocytic carcinomas included. This is important for the long-term prognosis aspects. And these were really extended pancreatectomies. 20 pancreatic duodenectomies, 60 distal pancreatectomies, 20 total pancreatectomies. And when you look, especially in the group of total pancreatectomies, almost 50% of these patients had 3 or more additional organs resected. It was the colon, it was the artery in the total pancreatectomy group, and 45%, and in addition, because portal vein resection was not in the definition those times before the ISGPS definition included in extended resection, so in addition, about 25% in the pancreatic duodenectomy group and 55% total pancreatectomy group additional portal vein resections. So these were invasive pancreatic resections. As awaited, the morbidity in these invasive extended resections is higher. 55% morbidity as compared to 42% morbidity. And we go into the mortality rates. The 30-day mortality rate in the standard resection, 1.5%. The 30 mortality rate in the multivisceral resection, about twice as high. And with the in-hospital mortality rate, again, twice as high in the multivisceral group, but due to the amount of patients, this was not significant. The long-term survival, not different between these two groups, multivisceral and standard. It was about 20-month median survival. So the ISGPS guidelines, again with all other manuscripts, they came to the conclusion that the morbidity in extended pancreatectomy is increased. The mortality is not increased, but when we go for arterial resections, the morbidity and mortality is increased, and this was mainly based on this meta-analysis. Professor Nakao will probably go more into this data, where the perioperative mortality was significantly increased in arterial resections. And when we come to the long-term outcome, the survival is comparable to a standard resection and is much better as compared to palliative chemotherapy. I showed you about 19 to 20 months. This was much better than the 11 months we had from the Conroy, the FOLFIRINOX trial. At the same year, this group, focusing on the NISQIP database with about 10,000 pancreatic duodenectomies. Here you have again the terms multivisceral and extended, and of those 10,000, 270 were with multivisceral and extended resections performed. When you go into this data, you see that in the multivisceral group, there were only 5% vascular repair, there were 3% additional hepatic resections, 58% colectomies, and the other ones 30% small bowel resections. So this was not comparable to the ones of our Heidelberg group. They were much more aggressive, but again in this analysis of the NISQIP database, mortality was more than twice as high, 8.8% compared to 2.9%. Morbidity was increased, and it was mainly bleeding, sepsis, shock, all the complications we know in pancreatic surgery that really makes time hard. The odds ratio was about twice as high, and we come into the in the analysis, only the colon resections turned to be a risk factor for morbidity and mortality in this work. Now, later on, we analyzed our Heidelberg data regarding or with the aspects of the ISGPS definition, and looked again into 613 extended pancreatectomies now, which we compared to 1,200 resections. Now, we only looked for primary pancreatic adenocarcinoma. It was all according to ISGPS definition. It was a single center experience, and it covered a time period of about 12 years. The extended resections, again, pancreatic duodenectomies, about half of it, the rest distal and total pancreatectomies. This was about the same. This was not the same because here we had 70% pancreatic duodenectomies and total pancreatectomies only in the standard group. This is the extended group. When you go for the mortality, in-hospital mortality in the standard group, 3.6%, 30%, 30-day mortality 1.8%, and 90-day mortality 5.3%. About, again, twice as high in the extended resection group, all significant. So we know extended surgery, for sure, it's more invasive, you need more blood, you need more transfusions, the surgery takes longer, and it has a higher morbidity and also a higher mortality rate. So higher mortality, for sure, that was not known before. Again, when you go into these resections, now the extended pancreatectomies only, look at the total pancreatectomy group. again, almost 50% more than 2 additional organs resected. The portal vein resection group, pancreatic duodenectomy 60%, and type 3, this is one where you do a segmental resection with a primary anastomosis, 80% in the total pancreatectomy group, and in the total pancreatectomy group, again, a high number of arterial resections, 22%. The multivariate analysis for in-hospital mortality turned out that only total pancreatectomy is the one there's an independent risk factor for in-hospital mortality regarding the surgical aspect. The comorbidity of the patient, sure, it's an multivariate, it's an independent factor, and then again, duration of surgery, this is where you go with a long operation into a risk for in-hospital mortality. The survival, comparison of extended and standard pancreatectomy, now we have with the higher groups a better focus on this aspect, and we had in the standard group 25-month median survival, and in the extended group 18.6-month median survival and 11.7-month median 5-year survival. This is better than the FOLFIRINOX group, and when you compare, for example, the data on IRE, there is not the neoadjuvant therapy here included. In this trial, about only 18% of the extended group and 10% of the standard group had neoadjuvant therapy. So this is more or less naive patients regarding the pre-therapy. And when we go into the multivariate analysis for survival, the R0 resection is important. The duration of surgery is important, the blood loss is important, but we could not find any relevance of colon, portal vein, or artery resection in this multivariate analysis in this really large group of patients. So, are there any limits of extended pancreatectomy? We were looking only on the surgical aspects, but it's not all. We all know that treating cancer, it's about biology, it's about selection, and it's the technical maneuvers where I was focusing before. This is the king, selection is the queen, and we are only the prince and the princess as the surgeons. Can we do better here to get better long-term survival? Sure, we know neoadjuvant therapy, you have seen this before. This is a role to get a better outcome. But this is only a small trial that had terminated earlier because of the monitoring board which stopped the trial. So the neoadjuvant therapy, this will definitely improve the outcome of patients with borderline resectable pancreatic cancer. But is everybody a good patient? Who is good for neoadjuvant therapy and who is good then after neoadjuvant therapy to be explored and to get a resection of the tumor? You see only 20% proceeded to resection in this neoadjuvant group, but the patients who had a lower CA19-9 levels, that are the ones that had a higher resection rate. And from our Heidelberg experience of more than 1,500 patients, where we looked at the CA19-9 level, we know a high CA19-9 level of more than 1,000 will only result in a R0 resection rate of less than 10%, and the 5-year survival in patients with a high CA19-9 level of more than 1,000 is 0%. So this is probably a parameter, the only parameter we have where we can really go into biology and see patients with a high CA19-9 level. These are the ones possibly who will benefit from the neoadjuvant therapy, and for sure when the level comes down we will definitely or probably benefit from the resection. Which is the best neoadjuvant therapy? We've heard a lot about it. In this trial, the different chemotherapies, they did not make a difference, but for sure it was much better than resection or non-resection. But we all know from the Project trial that has been just presented at the ASCO that FOLFIRINOX is extremely efficient in adjuvant therapy, and we know from the Conroy trial, also in palliative therapy, that FOLFIRINOX is really a good a good choice. From the Boston group, Christina Ferroni presented this yesterday very nicely. We can't use CT scan anymore after neoadjuvant therapy. It shows the same. We can't decide this is tumor, this is the scar. We go into surgery. We go into exploration. We have to use multiple frozen sections. And then when the frozen sections are negative, we perform the resection. Despite of these images, and Andy Walsher in this trial looked at all the CT scans and thought it's irresectable. Our serial resection could be achieved in 92% of these patients with neoadjuvant FOLFIRINOX. So we are not at the end. We have a lot of trials going on, running with neoadjuvant therapy. Is really chemo, radiotherapy the best? Is FOLFIRINOX the best? We don't know either. Is everybody a good patient with borderline tumor for neoadjuvant therapy? We don't know, but we hope we have more information on this. So my summary: don't be nihilistic. John Windsor told us yesterday that surgery will have a not big role anymore in pancreatic cancer. I don't think so. Surgery, including the extended pancreatectomy, is the cornerstone therapy to achieve long-term survival. With chemotherapy alone or radiochemotherapy alone, we don't achieve this, and the role and optimal type of neoadjuvant therapy, especially the type that has to be defined for locally advanced pancreatic cancer. And so I thank you for your attention.